Hello everybody, Dr. Carlo Ojet, board certified emergency physician, and I've been posting this video series on radiologic interpretation. Today we're gonna do a case to make it interesting, to put it on context, to actually feel like we're caring for patients and to go through the mental pattern of what we're gonna think as we see these radiological images. So this is a 21-year-old male who presents with a chief complaint of cough and hemoptysis. Hemoptysis, hemo, blood, tysis to cough, so coughing blood for the last 2 days. Has no past medical history, has an elevated respiratory rate of 28. Now, normal respiratory rate is between 12 and 15, so anything more than 16 is considered tachypnea, increased breathing rate, and a pulse of 110, which is actually high. For a normal person, 21-year-old, healthy guy, heart rate should be 80, maybe 90, so this is an elevated heart rate. Exam reveals scattered rows. And what are rows? Rows sound like wetness. Okay. While in the emergency department, the patient experienced increased respiratory difficulty. The oxygen saturation dropped. He increased his respiratory rate and ultimately required ET tube, endotracheal intubation. And his temperature increased to 103.6. That's very high temperature. So definitely something infectious. Just this alone, the fact that he was having respiratory of 28 and a heart rate of 110 would have put him as a possible SIRS patient, systemic inflammatory response syndrome, and in our emergency department would have activated a septic protocol, meaning blood cultures, lactic levels, fluids, and antibiotics and peer treatment. With a patient with a cough, we would treat it for pneumonia, possibly community acquired antibiotics type things. So let's go ahead and see what the x-ray looks like. Now, remember what we said about before. Grossly abnormal, grossly normal x-ray, grossly abnormal x-ray. You can already see there is a lot of haziness in here, in here. You can barely see that border right there, and you can see that there is something there that shouldn't be. That's an endotracheal tube. Of course, it's got wires so this is a portable film showing diffuse alveolar type infiltrates, or diffuse opacification of the air spaces on both lungs. This opacification, let me remove some of these so you can see it again, is uniform as opposed to a central distribution. In this patient, we're going to consider whether this is pneumonia, pulmonary edema, blood within the lungs itself, or even neoplastic type cancer type of things. In the young man with high fevers and diffuse air filling, we have to think about pneumocystic carinii pneumonia, PCP pneumonia, pneumocystic carinii pneumonia. And this might be related to AIDS, acquired immune deficiency syndrome. However, this patient denied any high risk factors for HIV infection. There are many causes for hemoptysis. Pneumonia and bronchitis are very common, but also tuberculosis and cancer have to be considered. And pulmonary edema can cause also coughing of blood, but it's usually like frothy, almost like foamy, bloody kind of stuff. But you need to think about pulmonary hemorrhagic disorders, meaning actually bleeding into lung tissue itself. This patient was admitted to the medical intensive care unit under broad spectrum antibiotics. He was not only given antibiotics to treat community acquired pneumonia like ceftriaxone and Z-Pak, but he was also given amikacin, Bactrim. He was given isoniazid because we want to treat tuberculosis potentially, rifampin. He was given ethambutol and frottericin B. He was hit with everything, right? After all that, and even with the IV steroids, he was not improving. He started to pee with blood, and a kidney consultation was done. A renal doctor was involved in the case, and he ordered an anti-glomerular basement membrane antibody. And these antibody levels were elevated, giving us the diagnosis of Goodpasture's syndrome. So an emergency plasmapheresis, which is to filter the blood for these antibodies, was attempted, but the patient was too sick and they had an ultimate demise. So the nice thing about this case and why we brought it up, obviously the type of x-ray we're looking at, very different from the ones we've already seen. And ultimately this is a very tough diagnosis. This particular case was not diagnosed by the ER doctor or the hospitals or the intensivist. It was actually diagnosed by the kidney doctor because you're the right test. And a basement membrane antibody test diagnosing with Goodpasture syndrome. So that's a very good case, rare disease, can present with hemoptysis, and then of course hematuria, which is bleeding in the urine. Hope you enjoy this case. Hope you learned something about it. Presentation, clinical picture, deterioration, how to look at an x-ray of an intubated patient, empiric treatment of antibiotics, and so on. Hey guys, we'll see you in the next video. I hope you're liking this series. Please make sure to like, comment, and I'll keep on doing them. Thank you. Bye-bye.